I'll be talking about Caries Risk Assessment. I shall be switching off my video because I'm not well. So pardon me for that. The generic meaning of any risk assessment is that use an individual's personal, genetic, and environmental information to determine a qualitative or quantitative value of risk for developing specific diseases. And when we talk of Caries risk, Per Excelson in 2000 gave a very good definition that it is the probability that an individual will develop at least a certain number of carious lesions reaching a given stage of disease progression during a specified period of time, conditional on his or her exposure stable during the period in question. So that means it is individualized risk which is trying to mention. And the another definition which is very popular, which was given by American Academy of Pediatric Dentistry is Caries risk assessment is the determination of likelihood of incidence of caries during a certain time period and involves the likelihood that there will be a change in the size of activity of the lesions already present. You all know that my previous speaker has explained in detail what is a risk factor, what are the risk factors, so I'm not going into the details. But yes, I'm just trying to remind you the same thing which the previous speakers have also spoken about early childhood caries is that we have passed through a phase of dentistry when initially at the time of Dr. G. Black, it was purely surgically drill and fill technique for dental caries. Then the late 19th century and the initial part of 20th century, we started talking of prevention, and so many types of fluorides came in, triple fluoride therapy, and we thought that one size will fit all. And actually, for the initial 3 decades, maybe from 1960s to 1990s, globally, there was a reduction in caries due to fluoridation and different types of fluoridation methods used. But after 1990, for the last 30 years, we have not been able to see much of difference. The dental colleagues across the world have been thinking more about it. And the current paradigm is that you do early intervention, do risk assessment, manage accordingly. You may plan anticipatory guidance even before start of the disease. And the prevention may be individualized uh, based on their own risk factors. So again, when we talk of individualized prevention and disease management, it only works in the clinical settings. It may not be possible in a community setting. However, some of our risk assessment tools also give us some of the indications which may work on a little larger group. Uh, However, for the purpose of this particular lecture of mine, I'll be focusing more on individualized caries risk assessment and management tools. So, most of the risk assessment tools have been based on existing knowledge of the risk factors, their occurrences. They have been developed and validated for specific populations. So some of the tools may not be relevant to our population, or some of the tools may require modifications. However, the commonest risk factors, which is diet, hygiene, and the tooth factor, are common in almost all the tools. There may be different way of looking at it, but these are the common. The tools developed, but their concurrent validation in terms of how effective they have been for long term for uh, management of dental caries risk and keeping somebody healthy throughout their life, they are still under debate. Some of them, some of the tools have got very good publications. associated with their usage. Some of them do not have yet, but yet it is the time when the dental professionals need to sit together, frame different strategies, and have long-term studies so that we use the caries risk assessment tools in a proper way for the final benefit of the patients. So, if I try to find out the list of caries risk assessment tools available, the list goes to more than 35 tools. Uh, I will not be able to cover all of them. I'll be covering a few of them, but yes, I'll be mentioning about some. So, the first and the foremost and mostly used caries risk assessment tool is given by American Academy of Pediatric Dentistry. It is popularly known as CAT. There's a little modification to this by American Dental Association, which is more generic to the adults, which is called as Caries Risk Assessment Tool, or CRA. Then in the start of this century, we saw a development of a tool by the name of Caries Management by Risk Assessment, popularly known as CAMBRA. Then there are little modifications to these tools are with certain newer functions are in the form of karyogram and traffic light metrics. Then around 2011, we came up with a newer system of caries diagnosis, which is ICDAS, and the same group which developed ICDAS, they developed the International Caries Classification and Management System, which is popularly known as ICCMS. And there is a little modification of ICCMS in the form of patient's utility kind of app, which is called as Caries Care International. There is one indigenous app developed by our colleagues in India. It is by the name of Craft, Caries Risk Assessment Tool for Treatment. So it also adds the treatment part. And there is one karyometer app developed for, it's mostly for the patients. So let's first talk about CAT, developed by AAPD. It was developed and adopted in 2002 and last revised in 2019. The aim was to educate the healthcare providers and other interested parties for caries risk assessment in pediatric dentistry and aid in clinical decision making regarding diagnostic, fluoride, dietary, and restorative protocols. So, mind you, this aim is to educate healthcare providers. So, therefore, it is more of educative. And yes, it has been used for the management and has been found to be effective in some of the studies. So they divided the caries assessment into two age groups, 0 to 5 years and 6 and above years. And they incorporated three factor categories. One is social, behavioral, uh, medical. Second is clinical, and third is protective factors. And the disease indicators appropriate for that particular age of the patient. It classifies caries risk of the individuals into low, moderate, and high risk. So this is the typical tool for 0 to 5 years olds. The risk factors which are related to social, behavioral, and medical factors, uh, and it's listed this side of the slide, and the other side of slide we can see that if that factor is present, where this child has to be labeled into high, moderate, or low risk. So, like among the social, behavioral, and medical risk factors, mother or primary caregiver has active caries. If it is yes, then the child is under high risk. If the parents have poverty or low health literacy, then it is high risk. Similarly, for frequent exposure of between meal sugar containing snacks or use of bottle, then it is high risk. Similarly, visible plaque, enamel defects, and child already has white spot lesions or visible carious lesions or recent restoration, then the child is under high risk. However, if the child is recent immigrant and has a special healthcare need, then it may fall into moderate risk. And then about all the protective factors like fluoridated drinking water, fluoridated toothpaste usage, twice daily brushing, topical fluoride application by the health professional, and dental home or regular dental care, then this is under low risk. So based on the overall assessment, you can mention the child as high, moderate, or low risk. The similar tool is for 6 years and above children, in which certain factors of 0 to 5 have been removed, like baby bottle feeding and mother's caries exposure. But they also added the factors which are relevant to this age group, like hyposalivation. There is a change in the special healthcare need also. In the previous one, it was for the high risk. Here it is for the low risk. Then among the other factors, the salivary flow has been added, use of interval appliance has been added, or defective restoration has been added. Uh, Again, based on the similar type of a table, we categorize the child into high, moderate, and low risk. So based on the risk classification, then further, the treatments have also been advocated for low, moderate, and high risk, and these are all known um, management methods, which I'll not be enumerating in details. Similarly, the management protocol for 6 years and above, again, they are known and standard methods for low, moderate, and high risk. I'm not repeating them. The pros, that it is a simple tool to use and it can be easily integrated into the clinical records. It provides a clear research-based caries management protocol. The cons is that they have not been tested. No report of its usefulness as measured by means of accuracy in terms of sensitivity, specificity, or clinical usefulness in terms of predictive values under varying levels of disease prevalence for either caries presence or incidence have been tested. Though there are limited number of publications available, but none of them is a long-term study and none of them is free of several biases. The APD CAT is a point in time assessment and it has not been clinically tested to provide predictive utility for future. It is not practical to use in low income populations because all children from the income families are classified automatically as being high risk. So for a country like us, all children would be falling in the high risk category. So we need to think of something else for our country. ADA, American Dental Association, in 2009 came out with the Caries Risk Assessment tool for children with the age group of 0 to 6 and above 6 years. It is basically a questionnaire that contains various factors like contributing factors, general health conditions, and clinical conditions. And based on this questionnaire, you can again categorize the children to low, moderate, and high risk. So this is a kind of a chart which is more or less similar to the previous chart which I have shown for AAPD. The only difference is that they have added the siblings caries also as a risk factor rather than only the parents or caregivers. Then they also have put the special healthcare needs into high risk. In the previous one, it was on the moderate risk. And this particular classification also adds up certain aspects like visual and radiographic evidence of caries and extent of caries rather than only presence of caries. Similarly, for the 6 years and above group, the chart is nearly the same with certain additions of eating disorders, medications, or drugs usage, or radiation therapy. These factors have been added for this particular age group. Unusual tooth morphology, interproximal restorations, exposed root surfaces, overhangs, open margins have also been added in this case. The ADS CAT is simple to use and easily integrated into clinical record. Additionally, this tool encourages additional clinical examination to determine risk and guide treatment planning. The cons are that it is again a point of time assessment and clinically has not been tested to provide the predictive utility. Now comes the popular risk assessment tools for pediatric dentists. It is by the title of Cambra, and this is a little more sensitive tool in terms of children. It represents an evidence-based approach for preventing, reversing, and treating the dental caries. So mind you, the word is reversing here. They have also targeted that even if the cavitation has not occurred, you can reverse. And the Cambra gives emphasis on the whole disease process, not on just the cavitated stage of lesion progression. So they talk mainly about the caries balance. We know about the pathological factors and protective factors. Pathological factors have been named as bad, and the protective factors have been named as safe as an acronym. You all know about it, so I'm not going into the details of it. And I think Dr. Ashwin Javdekar has already covered these in details. It's only that by evaluating the caries balance, you can find out which direction the child's oral cavity is going. And based on the type of risk, you can plan interception, prevention, and treatment. So again, this has got two age ranges, 0 to 5 and 6 years through adult. And it is 3 sections. One is the disease indicators, second is risk factors, and third are protective factors. So how to measure the risk of developing caries according to Cambra? First is the detection. So you have to use a very sensitive method of detecting. Again, it can be 3 diagnostic groups, one with active, non-cavitated and cavitated caries. Second can be when the demyelination is in balance with no further caries attacks at the time. So the caries balance is already there. And when caries undetermined diagnosis, when characteristics of both groups are present, means the active caries is also present and somewhere some of the lesions are in the caries balance group. So after this, we can also do the bacterial test for the Streptococcus mutans and Lactobacilli for the prediction of the disease. And based on this prediction, again, we have a chart with the similar type of parameters, but having the more emphasis on the dental caries lesions and the microbial count. They also cover protective factors, and major thing in this is that they have enumerated not only the toothpaste use, but the mouthwash use, fluoride varnish use, office topical fluoride, chlorhexidine, xylitol, calcium and phosphate pastes, and salivary flow. And again, the risk has been categorized into 4 categories here, into extreme risk, high risk, moderate risk, and low risk. The chart of the Canberra is looks like this typical chart with the caries balance, and you see in the bottom that there are 4 different categories, which defines the caries. This is similar chart for the age group of 6 years and above. And based on the risk category, then the management has been listed. Again, these are the standard management things, and there's nothing new to speak about, which you have already heard in the previous lecture. So there is no guarantee that a patient will stay in the same risk groups in the future, and the change in the balance between the protective and pathogenic factors may shift the patient to a different risk level over a short period of time. The goal is to get the patient into a lower risk group if possible. So it is a simple and straightforward tools, but the cons of this that in practice the camera interviews are used as complete risk assessment. The factors identified on the interviews do not have relationship with the case risk. All the factors do not have uh, do not indicate the direct relationship with the case risk, and they have not been tested for a predictive value for future caries incidents. Again, it is a point-in-time measure of risk. However, the preventive services and recall recommendations up to 12 months for a periodic exam and 24 months for the radiograph for low-risk children do not account for sometimes rapidly changing circumstances that can drastically modify the risk in a short period of time. So this particularly pertains to age group of 2 to 5 years when there is a quick change in the oral environment. And sometimes if you have classified a child at the age of 2 years into low risk, it may quickly change. And when you call after 12 months, suddenly it goes into very high risk. So therefore, you may use camera, but use your own wisdom for more frequent follow-ups. Now comes Karyogram. As the name suggests, it is an interactive computer program which was first developed by Brathel in 1996. It represents a graphical picture that illustrates a possible overall caries risk scenario. It shows that the risk for developing new caries is also a chance to avoid new caries in future. And it typically looks like this kind of a colorful chart in which there are different color sheets given for diet, bacteria, susceptibility, circumstances, and finally actual chances to avoid the caries. It makes the whole one big pie chart. The calculations are based on the four factors which I mentioned. In terms of diet, based on type of diet being used and diet frequency, you have to give the scores. Like very high diet frequency is more than 7 times for 24 hours has been given as rating of 3. And when there is a highly fermentable carbohydrate intake and inappropriate diet, again that has been given as a score of 3. Similarly, for the plaque amount and score of mutant streptococci, the scores have been ranked from 0 to 3. Then for the susceptibility in terms of salivary secretion, so right program and salivary buffer capacity, again the scores have been given from 0 to 3, and for buffer capacity is 0 to 2. Then other circumstances like in the oral cavity, if there are filling, what is the status, current general diseases. Based on that, again, there are scores. So when you do this input of the scores, then you get the karyogram in the screen, the colorful chart, pie chart comes, and in that you can find out if there's a small green sector, there are low chances of avoiding caries. That means the child is at high risk. And if there is a large green sector, then it's a low risk. So it works on simply examining the patient, asking some questions related to relevance of caries, factors relevant to caries, uh, bacteria count, and these given scores are fed into the computer. And according to the previously built-in formula within the computer, means there are certain algorithms. The pie diagram is shown on the computer with the weightage. So a typical pie chart looks like this. For a particular child, if the score for caries experience was 2, other related diseases were not there. The diet content score was 3, diet frequency score was 3, the plaque amount score was 2, mutant streptococci score was 2, fluoride program was 2, salivary secretion was 0, buffer capacity was 1, and clinical judgment based on the examination was 1. So based on that, you can see that this particular child, because the diet score is 3, 3, plaque amount also 2, caries, previous caries also exist. So therefore, the green part means the actual chances to avoid the new cavities was only 13%. So that means this child is at a high risk of caries. The pros for this karyogram is it is a very comprehensive and exhaustive approach, but yes, it takes time. This process includes questionnaire, interview, estimation of oral hygiene, salivary sampling for bacterial count, and the quantity of saliva. So it's very extensive, but yes, very useful. The cons is that the use of this program, it includes salivary test and with microbiological cultivations. That means you get the reports after 3 to 4 days. So 3 to 4 days, whether you treat the child, how do you treat, uh, how to take care for those 4 5 days till the time your results are coming. So that is one of the challenge. So it takes long time, and it is a very costly process, costly time consuming both. So similar is another that's called as traffic light matrix. It is based on 19 criteria and 5 different categories. These categories are saliva has got 6 criteria, plaque has got 3 criteria, diet has got 2 criteria, fluoride exposure has 3 criteria, and modifying factors again 5 criteria, where the traffic lights are showing varying risk levels. That means red is high, yellow is moderate, and green is low. So these are the simple factors which has been mentioned on this slide. I'm not going into the details, but these are the simplified form. And when you mark on this chart of the traffic light matrix, at the end you get the oral assessment about all 6 factors at the bottom. And once you get all of them, you can classify into high, low, or moderate risk. Now comes the ICCMS, or the International Caries Classification and Management System. This was developed by a global group of people, those who work on dental caries, and the founders of the ICDAS system of caries detection, Dr. Ahmed Ismail and Dr. Nigel Pitts. They are the main key people behind developing this global collaboration in King's College London. Largely, these people have been working more on the risk uh, classification, and they've come out with a very comprehensive system. So what is ICCMS? It is a comprehensive set of clinical protocols that addresses all diagnostic, preventive, and restorative decisions necessary to preserve tooth structure and restore only when indicated. It is a patient-centered, biologically compatible system which is evidence-based, preventively oriented, and safe for tooth structure. It is a high health outcomes focused system that aims to maintain health and preserve the tooth structure. The key features of this is that this system tries to prevent new lesions from appearing, prevent existing lesions from advancing further, and preserve the tooth structure with non-operative care at more initial stages and conservative operative care at more extensive case stages. So how it works? It also has a system in which all the protective and damaging factors are taken into consideration. So there's basic reporting tool, then there's a merge course of recording system, and there's a full ICDAS caries scoring system. This is education model, and then the comprehensive care plan includes the questions about history, the classification of the dental caries, it means staging and activity assessment, then the management based on the personalized caries prevention, control, and tooth preserving operative care, and then finally synthesis and diagnosis. So it works on five keystones. First keystone is Caries staging and lesion activity, in which you do the examination of the child. Keystone 2 is the assessment of the patient's Caries risk status based on the examination and certain questions about the diet and hygiene. Based on these three things, you synthesize and diagnose about the likelihood of caries. Then, based on these three, you make a comprehensive caries care plan in which you try to see what is the likelihood of new caries and progression for this patient, as well as find out the caries lesions are existing and the caries activity status on the tooth surface. Based on this, you get low, moderate, or high risk, but you may have sound and you can prevent new lesions. You may have inactive caries lesions, but you still have to do risk management. And if you have active initial, moderate, or extensive caries, based on that, you do non-operative or operative care for the treatment. And then you have recall interval, and that is comprehensively planned for the outcomes, overall outcomes. But this particular stage, as you see, the arrows are pointing again back to keystone 1. It means that it is a continuous process. It has to be taken care frequently at every appointment. So these are the details of the each element, like history taking. In this history taking, you go from head and neck radiation to dry mouth to oralizing practices, fluoride usage and sugar usage, socioeconomic status, health access barriers, which has come for the first time, and mothers or caregivers caries level. The second element for identification is the classification of caries, staging and activity assessment. Then these are the simple examples of ICDAS 0, 1, and 2 score, how to score them. Then in the moderate stage is ICDAS 3 and 4. And in the extensive stage, we have ICDAS 5 and 6. You all know about this classification, so I have not repeated this. But the activity assessment is very important, that what is the sign of active lesion. So uh, please do not record only in your OPD card that what is the lesion or what extent of the lesion is. If you try to see what is the boundary of the lesion, or this, if the surface of the enamel is whitish or yellowish or opaque with loss of luster, it feels rough when the tip of the probe is moved gently across the surface, or the lesion is a plaque stagnation area, then it means it is an active lesion. Whereas if it is the surface of the enamel is whitish, brownish, or black, enamel may be shining, feel hard and smooth when the tip of the probe is moved gently across the surface. This lesion is typically located at some distance from the gingival margin, and lesion is not covered by the thick plaque prior to cleaning, then it is an inactive lesion. So even if they are classified as the same level in ICDAS system, but they may be active or inactive lesions. So this is very important for you to record. See this example of active and inactive lesions in this picture. Um, so if the lesion is active, your risk categorization is different, and when the lesion is inactive, your categorization is different. Similarly, this system also tries to explain you the staging of the lesions with the radiographic methods. You can see that they have given for the intraproximal lesions, it is staged into RA1, RA2, and RA3. RA4, 5, and 6 is also there for the extensive and moderate lesions. The third element is the decision making based on the caries activity, based on likelihood of new caries and progression. So you synthesize and do the diagnosis, and then your diagnosis is based on the combined categories and activity status. And this is how your matrix is visible, that how will you classify to low, moderate, and high risk based on your caries lesions activity and extent of the caries. Now, the next keystone is next element is management. The management is always personalized and it has got several components. Uh, we do tooth preserving operative care for the lesions. We may do non-operative care of the lesions for controlling, and we may prepare the sound teeth that they do not get caries. So that's how it is holistic approach. So as of now, no studies have evaluated ICCMS system in a complete manner. We have done one in our department, but we removed some of the criteria to make it more practical. And we try to do, the publication is still pending for that. Once it comes out, then I'll be in a better position to explain you. Similar to our department, I could see two more such publications coming up, but all of them mention that it needs further evaluation. So the global collaborative for caries management, the one which developed this system, they are in a process of developing a common protocol, and they're asking various people to partner with them to see that how ICCMS works. The principles of implementation of ICCMS are, I've already mentioned actually, the preserving, preventing, maintaining, and improving, and updating the risk status in a timely interval. Staging and lesion activity recording is very important for we as a clinicians, and prevention of the development of new caries lesions. So the same system, ICDAS and ICCMS, um, that has been further developed into a four-dimensional system, and has been popularly named as Caries Care 4D. It is more of a patient-friendly, and again, the developer of this mentioned that it is a consensus guide. Many of the things, they do not have the direct evidence, but anecdotal evidence they have used. And they have tried to summarize and make it smaller and more patient friendly. This is a kind of a software app which uses a similar system as ICDAS, and it gives you a very quick assessment. The Caries Risk Assessment for treatment, or the craft, has been developed indigenous in our country. It is a simple chairside, non-invasive, and 4-point approach for the management of caries based on the risk assessment. It is available in the form of a physical chart also, and a digital tool in form of a mobile app. It includes the 4 parameters: diet, decay, fluoride exposure, and other factors. And uh, there's a range which can be determined for the caries risk. It's not 3 distinct categories. They also use the similar to traffic light, green star is used to indicate safe, and red star is the risk. So these are the 4 categories, similar, mostly similar in all of the uh, risk assessment tools. But yes, they have tried to summarize, they have tried to reduce the number of factors. But one important thing which they have kept in mind is, for the Indian population, hypomineralization, conditions related to suppressing the immunity, malocclusion, crying, and hyposalivation. These are more given more emphasis than the other. So this is a snapshot of the digital tool, how it looks on the mobile screen, and it gives you the score in these four type of stars. So star can be red or green. So based on the risk ascertained from the craft, the same tool, the same app gives the home measures also to the patient. So this is not only for the doctor, but for also for the patient, and it gives the common instructions for the patients, which are evidence-based and which remind the patient on day-to-day basis for the instructions. Similar to Craft, there is one more Cariometer app has been developed. It is nearly with the same type of algorithm, and here you will see a score of alert in the form of a meter. And a typical Cariometer app looks like this. So coming to the last part, the importance of caries risk assessment is that it gives economic sense to target the preventive treatments at appropriate risk groups. You may not do the same thing for all. It is based on more of an individual approach. The recall interval is based partly on the risk of the disease progression. The most of the risk assessment tools also gives us opportunity to explain the parents and the patients that they become aware of their risk status, and accordingly recall appointments are maintained, and the patient and the parent are also involved in their own preventive care. A repeated determination of the risk allows the evaluation of the success or need or the modification of the preventive measures, and dentists are aware that the risk can change over a period of time. So to conclude, the caries risk assessment is a very powerful tool. It can help in curbing unnecessary operative dentistry. One size may not fit all. The factors vary in different geographic and socio-economic zones. Therefore, the modifications and adaptations are required. However, the major four factors remain stationary for all caries risk assessment. The evidence on efficacy of various caries risk assessment tools or systems are limited. As of today, it's very difficult to point out a single predictive variable because it is a multifactorial disease. So, in conclusion, I want to say one line that all caries risk assessment tool, whichever you feel comfortable, you should use. These are general guiding principles, but also prioritize your clinical judgment over and above these tools. Please do not go verbatim by any one of the tool. Use your own clinical judgment. Thank you very much.